Hello and good evening, everyone. Welcome back to our Sunday 9 p.m. show of Iron Talks. We've been covering a different lot of topics, and we've been trying to touch anemia and related issues from different medical streams. We've covered so far different topics such as anemia related to nephrology, oncology. We've addressed the issues of anemia relating to heart issues, and many other interesting topics. We are yet here again back with the today's session with a very interesting topic, that is anemia and endocrinology. For the same, let me call Sambit Das, who is a senior endocrinologist and has a lot of experience, which I'm sure he'll be sharing with us. Sir, very warm welcome and good evening, sir. How are you, sir?
Very good evening. Very good
So,
evening.
right, sir. So, sir, this platform is basically, as you've already know, that this platform has a lot of medical fraternity people who, despite their busy schedules, find time to come down to watch this show because of the content that we bring forward on this platform. And I am sure, sir, today's topic about endocrinology and anemia will be equally very important and very thrilling. So, sir, the stage is all yours. Thank you, sir.
Thank you, Mr. Karan. Can I just see my slides? Yeah, yeah. A very good evening, one and all. And at the outset, I must thank Dr. Sanjay Kalra sir for giving this opportunity. I must thank the team IJCM and the Heart Foundation for giving this opportunity. And today I'll be discussing on a very unusual topic, that is endocrinology of anemia. It's not when the topic was given to me some uh, 1 month back, so I was actually confused what to speak. Then while searching and preparing for the slides, I found that the topic is very fast, because endocrinology and anemia are very closely interlinked. And I'll show you in this further slides how they are closely related. So in the agenda, I'll discuss on 5 or 6 important topics. That is, first is endocrinology of erythropoiesis, because uh, a important hormone known as erythropoietin is very much essential for proper erythropoiesis. Second, I'll be discussing on anemia as a comorbidity in different endocrinopathies, because we'll find anemia in diabetes, we can find anemia in hypothyroidism, we can find anemia in parathyroid disorders like both hypopara and hyperparathyroidism. We can find anemia in hypogonadism, hypopituitarism, and also there is an association with autoimmune polyglandular syndrome. So anemia is associated with many endocrinopathies that we must understand. Second, I'll be discussing about anemia as a diagnostic tool for endocrinopathies, because sometimes uh, we diagnose a condition or an endocrine problem just by seeing the hemoglobin and the peripheral blood picture. For example, in Sihan syndrome, where anemia with absence of menstruation can be an early diagnostic feature. Similarly, Addison's disease, hypogonadism, DKD can be diagnosed or can be suspected from anemia only. Then I will discuss the fourth point, that is anemia as a confounding factor. We all know that we have a marker known as the HbA1c or glycosylated hemoglobin that we test for measuring the glucose level for the last 3 months in person with diabetes. But HbA1c can be it can show abnormal results when different types of anemia would be there, and there would be a confounding factor. So I'll be discussing on that point. The next I'll be discussing on anemia as a therapeutic tool in endocrinopathy. Like, therapy for endocrinopathies may improve anemia. For example, if you are giving testosterone therapy for a hypogonadal male, then probably our hemoglobin level will go up. After parathyroidectomy in hyperparathyroidism, the anemia level or the hemoglobin level can go up. After thyroxine replacement in hypothyroidism, or in that sense, if after glucocorticoid therapy in Addison's disease also, the hemoglobin parameters can go up. Therapy for endocrinopathies, including anemia. So there are some endocrinopathies, especially management of diabetes, where we use certain drugs that may induce anemia. For example, we use pioglitazone, we use metformin that can actually reduce the hemoglobin level. At the same time, we use certain drugs like SGLT2 inhibitor or maybe a DP4 inhibitor that may actually have positive impact on hemoglobin level, or that may improve the hemoglobin level. So those part also I'll be discussing. Endocrinopathies in anemia I'll also discuss. For example, I'll discuss one slide on uh, how some of the anemia condition like thalassemia and sickle cell disorder can have different endocrinopathies, and we need to see different endocrinal abnormality in this type of anemia. So these are the 5 or 6 points over which I'll be discussing in my further presentation. So, coming to endocrinology of erythropoiesis and role of erythropoietin. In fact, erythropoietin is an hormone, and that is responsible for the most vital steps in the maturation of burst forming unit or colony forming unit of erythroid precursors, where finally an erythrocytes or an RBC is formed. And in that way, endocrine system is very closely related with erythropoiesis. For example, in the bone marrow, we have hematopoietic stem cell that is usually converted into megakaryocytic erythroid progenitors in that erythroid lineage. Then we have the burst forming unit, the colony forming unit, then the proerythroblast, then the polychromatic erythroblast, and then finally the reticulocyte and erythrocyte. Erythropoietin as a hormone which is produced by hypoxia. When hypoxia induces the kidney to produce erythropoietin by the pericytes, it actually activates the colony forming unit, the burst forming unit, and the proerythroblast to accelerate the erythropoiesis, and more amount of RBCs are generated. So in that way, the erythropoiesis is strongly interrelated to a hormone known as erythropoietin. Erythropoietin has long been recognized as the physiological regulator of RBC production. It is produced in the kidney and the fetal liver in response to hypoxia. Usually, in the fetal life, the liver is the major source of erythropoietin, but in adult life, it's the kidney which produces erythropoietin. Specialized interstitial cell in the inner cortex and outer medulla of the kidney respond to hypoxia by producing and secreting erythropoietin. If you see this diagram, I think this clearly describes how erythropoietin induces the erythropoiesis. In fact, when there is hypoxia, there is an hypoxia-inducing factor alpha and beta which are produced. They in fact help in They in fact activate the erythropoietin gene, and more amount of erythropoietin is secreted. And this erythropoietin binds to the erythropoietin receptors of burst forming unit and colony forming unit to produce further lineages and erythrocytes. But when the hypoxia is not present, or when there is a normoxia or higher oxygen concentration, then probably you will have this hypoxia inducing factor alpha being ubiquinated, and they are degraded. So the erythropoietin is gene is not active, and more amount of erythropoietin is not produced. So there is a very delicate balance of this hormone in regulating the erythropoiesis. Beside erythropoiesis as a true hormone, it is secreted from the kidney, and it is released into the circulation, and it acts in different parts of our body. And the major is red blood cell erythropoiesis. The other target organs for this erythropoietin hormone is brain, where it has been shown to produce some protective effect against ischemia or injury. In the endothelium, it maintains the vascular tone. In the heart, it protects against ischemia. Myoblast, it provides wound healing. So probably one of the mechanism of diabetic foot healing or any ulcer healing, sometimes we use erythropoietin, and it was used in the past also. In the bone, there is a remodeling, and in the white fat, there is a protection against obesity. So there are many actions of this erythropoietin besides erythropoiesis. So the first part of erythropoietin as a hormone and how it controls the erythropoiesis we have discussed. Now let us come to the second point, that is anemia as a comorbidities to endocrinopathies, and anemia can be a comorbidities in various endocrinopathies. Say, for example, diabetes, thyroid, parathyroid, hypogonadism, hypopituitarism, and also autoimmune polyglandular syndromes. Anemia and diabetes, just for the sake of completion, the WHO definition of anemia has been defined as when the hemoglobin is less than 13 grams per deciliter in men, less than 12 grams per deciliter in normal women, and less than 11 grams per deciliter in pregnant women. The prevalence of concurrent anemia and diabetes mellitus ranges from 14 to 45%. The risk of anemia in patients with diabetes is estimated to be 2 to 3 times higher than the patients without diabetes. So, diabetic patients have more chances of anemia compared to those where it is not there. And this relation is bidirectional. What do we mean by bidirectionality? Diabetes, people having diabetes have more chances of anemia. Similarly, anemia can affect diabetes in terms of poor outcomes in the complications. Say, for example, nephropathy, retinopathy, and the cardiovascular outcome are actually poor when anemia is present in diabetes. So, I'll be discussing in the subsequent slides. So this is basically a diagram which depicts how diabetes mellitus leads to anemia uh, uh, by its various causes, and one of the important causes is probably a chronic state of inflammation that can reduce the erythropoietin or produce erythropoietin resistance. The other features are increased advanced glycosylated end products. Chronic kidney disease per se can induce lowering of the erythropoietin. Chronic hyperglycemia, diabetic neuropathy, because of the poor sympathetic drive, it may reduce the erythropoietin secretion. Increase in the oxidative stress, reactive oxygen species that produce EPO resistance, and abnormal lifespan of the RBC, use of metformin and S and ARBs, malabsorption, vitamin B12 deficiency, or in testosterone deficiency also. So all these factors can actually lead to lowering of the erythropoietin production and decrease in the functional erythropoietin, and finally may land up in anemia. Type 2 diabetes, iron and erythropoietin deficiency, and hyperresponsiveness to erythropoietin are probably the most plausible causes of anemia in diabetes. The production of erythropoietin is modulated by sympathetic nervous system. So when diabetes is advanced, when there is diabetic autonomic neuropathy, so probably the sympathetic nervous system is also inactive, and that reduces the erythropoietin secretion. Chronic hyperglycemia could also potentially lead to increased apoptosis of renal tubular cells and hence reduction in the erythropoietin, and several other factors contributing to chronic hypoxic environment in the peritubular epithelium that may lead to lowering of the erythropoietin are diabetic nephropathy, chronic inflammation, abnormal RBCs, which we have discussed, and the nutrient deficiency like iron, folate, and vitamin B12, also with low testosterone. So all these factors are related to lowering of the hemoglobin in patients with type 2 diabetes. Inflammatory cytokines are thought to be involved in apoptosis of erythroid progenitor cells, and hyporeninemia and urinary loss of erythropoietin has also been hypothesized to be possible mechanism for anemia in this setup. Now that was about type 2 diabetes. Let us see about what are the causes of anemia in type 1 diabetes. Anemia in type 1 diabetes is mostly attributable to autoimmune causes, and mainly autoimmune gastritis and pernicious anemia, because there are various autoimmune disorders can be associated with diabetes mellitus, and autoimmune gastritis and pernicious anemia are two important things that can induce anemia. Patients having autoimmune gastritis are frequently diagnosed with iron deficiency anemia that may precede the pernicious anemia, or both conditions may also coexist. Iron deficiency anemia is observed in 20 to 40% of patients with type 1 diabetes, while pernicious anemia we can find around 15 to 20% of patients. Type 1 diabetes is also associated with some malabsorption disorder like celiac disease, and celiac disease, because of its inflammatory immunomediated enteropathy, it reduces the absorption of the iron, vitamin B12, and all, and that may lead to anemia also. Another common causes of anemia in type 1 diabetes is associated hypothyroidism. We'll be discussing how hypothyroid is associated with anemia also. Anemia role in complications of diabetes, I have told that this anemia and diabetes have bidirectional relationship, that we have discussed that with diabetes we have more number of patients with anemia. Now anemia can have adverse effects on diabetes also and its complications. So what are they? Diabetic kidney disease. Anemia may contribute to the progression of kidney disease in patients having diabetes, which can further aggravate anemia, and it completes a vicious cycle. Anemia may accelerate progression of kidney disease by increasing the glomerular pressure and proteinuria due to increased renal sympathetic nerve activity. The combination of anemia, diabetes mellitus, and chronic kidney disease compounds the risk of cardiovascular disease, stroke, and increased hospitalization and mortality. So, whenever anemia is there in CKD, that actually increases various other complications. That was about the kidney. About the retina. Low levels of hemoglobin or hematocrit and RBCs increases the risk of diabetic retinopathy, affecting almost 28% of patients. A hemoglobin level of less than 12 doubles the risk of developing retinopathy, and less than 6 grams per deciliter almost very high chances of developing proliferative and non-proliferative diabetic retinopathy. Retinal hypoxia is the key component of diabetic retinopathy, we know, and as the anemia worsens, the hypoxia gets aggravated and the retinopathy gets aggravated. It is hypothesized that the retinal hypoxia increases the production of vascular endothelial growth factor and causes retinal neovascularization and proliferation. Cardiovascular diseases, anemia is considered to be an independent risk factor for cardiovascular morbidity and mortality. The prevalence of anemia among patients with diabetes having chronic kidney disease and heart failure is almost tenfold. And left ventricular hypertrophy and heart failure are also quite common when anemia is present with diabetes, leading to peripheral vasodilatation and fall in blood pressure, which further causes activation of sympathetic nervous system and reduced renal function. So basically, all the cardiovascular morbidity and mortality are also increased when anemia is present with diabetes. Foot ulcer is another complication of diabetes that gets aggravated when anemia is coexistent. The prevalence of anemia in diabetic foot ulcer is around 49 to 62%, and anemia is frequently associated with lower extremity amputation, increased hospitalization, and mortality in patients with diabetic foot ulcer. Anemia may impair diabetic wound healing through reduced action of HIF, which causes decreased oxygen availability and impaired cellular metabolism. So these were the association of anemia with diabetes and how they are bidirectional. Now let us see the association of anemia in thyroid diseases. And the most frequent type of anemia reported in hypothyroidism is normocytic, normochromic, followed by microcytic hypochromic or macrocytic anemia. In a study of Erdogan et al., the prevalence of anemia in patients with overt and subclinical hypothyroidism was similar, reached up to 43 to 39% respectively. Most common cause of anemia in hypothyroidism is hypoproliferative erythropoiesis, leading to normocytic normochromic anemia. Anemia in hypothyroidism may result from bone marrow suppression, decreased erythropoietin production, comorbid disease, and associated iron, vitamin B12, and folate deficiency. The autoimmune thyroid disease and hypothyroidism may be related to pernicious anemia and atrophic gastritis, and celiac disease also may be associated with hypothyroidism as a spectrum of autoimmune phenomenon. And all these things can lead to anemia in due course of time. Iron is vital for the activity of thyroid peroxidase. The reverse is also true. Now we knew that hypothyroidism can lead to anemia. Now we'll discuss how anemia can also affect the thyroid function, because we know there is an enzyme known as thyroid peroxidase in the thyroid, which is responsible for the important steps in the thyroid hormone synthesis, and that is an iron dependent enzyme. So when iron deficiency anemia is there, then thyroid peroxidase will also act low or act slow and slow, so hypothyroidism can also be induced. So the relative risk of hypothyroidism in children with iron deficiency anemia is found to be 5.5 in overt hypothyroidism and 1.9 in subclinical hypothyroidism in comparison to non-anemic children. Coming to anemia and hyperparathyroidism, this is a very important evolving concept because it has been found that in primary hyperparathyroidism, 5 to 30% of the individuals have anemia. And anemia in PHPT or hyperparathyroidism is multifactorial, and most important cause is probably marrow fibrosis. And the underlying mechanism of marrow fibrosis is that the elevated parathyroid hormone, which have a stimulatory effect on the marrow fibroblast, and that may lead to bone marrow suppression and bone marrow fibrosis. And PHPT with underlying osteitis fibrosa cystica is more prone to developing marrow fibrosis compared with other PHPT manifestations. Anemia in adrenals. Adrenal gland is also closely related to anemia. A normocytic normochromic anemia may be seen in primary adrenal insufficiency like Addison's disease. The concomitant reduction in plasma volume in Addison's disease may mask the anemia. And pernicious anemia occurs in patients with autoimmune adrenal insufficiency. For example, primarily seen in patients with type 1 polyglandular autoimmune syndromes. Anemia in gonads, testosterone levels are directly correlated with hemoglobin levels in a community population of males between 30 to 94 years of age. So, lower the testosterone, the lower the hemoglobin level. Another study of elderly male of 70 to 80 years of age also found a correlation between hemoglobin and low testosterone level. The erythropoietic effects of androgen have been widely exploited in the treatment of various anemias, especially before the development of recombinant erythropoietin. So, previously, when recombinant erythropoietin was not available, then androgens were actually used to stimulate erythropoiesis. Data regarding the role of estrogen is conflicting, of course. Anemia can also be found in pituitary insufficiency where there is a multiple pituitary hormone deficiency, and they are usually normocytic normochromic and the hemoglobin ranges around 10 grams per deciliter. Red cell survival is normal in hypopituitarism, but the marrow is hypoplastic. Replacement therapy with combination of thyroid, adrenal, and gonadal hormone usually effectively corrects anemia and other cytopenias. So these were some of the important things about anemia and endocrinopathies, and then we'll discuss about the fourth point, that is the anemia as a therapeutic tool. So till now we have discussed about the association. Now let us discuss about anemia as a therapeutic tool. Therapy for endocrinopathies improve anemia, and there are some therapies for endocrinopathy which can induce anemia. So we'll be discussing in brief about them. And we have seen that testosterone replacement in hypogonadal male can actually improve the hemoglobin level. And this has been shown in this particular trial where elderly male with low testosterone level, when given testosterone replacement, the hemoglobin level could go up to 1 gram per deciliter, uh, and there would be a significant improvement in anemia. Measurement of testosterone level might be considered in men 65 years of age or older, where there is an unexplained anemia, where you do not find any cause. Probably we can check for a testosterone level also. It has also been shown by a large and good trial from PGI Chandigarh, where they've actually shown that in primary hyperparathyroidism there would be marrow fibrosis that leads to anemia, and this anemia can be recovered or can be reversible after successful parathyroidectomy. So anemia and marrow fibrosis in patients with symptomatic primary hyperparathyroidism improved after curative parathyroidectomy. Beside that, there are some treatment that leads to anemia. For example, in diabetes we use metformin, and metformin therapy has been associated with B12 deficiency because of the malabsorption of vitamin B12. Evidence has shown that approximately 10 to 30% of patients on long-term metformin therapy tend to experience vitamin B12 malabsorption. Increasing age, dose, and duration of metformin influence the risk of developing vitamin B12 deficiency. Thiazolidinediones induce anemia probably because of expansion of body fluids, volume, and impaired hematopoiesis due to fat accumulation in the bone marrow. And the bone marrow progenitor, the precursor cells will be converted more to the fat rather than to erythropoiesis. That is the cause of anemia. S and ARBs, which we use for hypertension and diabetes, may are may induce anemia in diabetic patients because angiotensin 2 is a key regulator for erythropoiesis and also an important factor for growth of erythroid precursor. The use of S inhibitors or ARB influence the erythropoietin action of angiotensin and contributes to the development of anemia. In contrast, the other two drugs like DPP4 inhibitors and SGLT2 inhibitor may actually improve anemia because DPP4 inhibitor may improve the erythropoietin production by inhibiting the altered DPP4 enzyme on certain interleukins, chemokines, and erythropoietin. And recently, it has been shown that if DPP4 inhibitors are given in patients who are CKD on erythropoietin therapy, then the dose of erythropoietin will probably be reduced. The SGLT2 inhibitor have also shown improvement in erythropoietin level through its renoprotective action by inhibiting the tubulointerstitial hypoxia and oxidative stress. So those were about the therapeutic tool, anemia as a therapeutic tool in endocrinopathy. The fourth point which we will be discussing is anemia as a diagnostic tool for endocrinopathy. Now, as I have told that Sheehan syndrome many times can be diagnosed with a lady who has developed amenorrhea. At the same time, there is severe anemia. So anemia is a marker that probably the lady is having Sheehan syndrome. Addison's disease, we can sometimes anemia is a marker, and hypotension, anemia, and pigmentation can be a picture for Addison's disease. Similarly, unexplained anemia in elderly male where other causes have been ruled out, probably we need to see about hypogonadism in this group of patients. DKD in diabetes can induce severe anemia. Hypothyroidism patients sometimes can present with anemia and with fluid overload that we have to scrupulously see. Anemia is a confounding factor, which I'll be discussing regarding HbA1c interpretation, is a very important concept because there are condition. HbA1c is a very important tool for diagnosis or for monitoring a patient with diabetes, and it tells about the last 3 months blood glucose level. Conditions that increases the life of erythrocytes are associated with decreased turnover rate of RBC can actually falsely elevate the HbA1c level. For example, iron deficiency anemia, vitamin B12 or folate deficiency are associated with spuriously elevated A1C level in patients with or without diabetes. Conditions that reduce the survival of erythrocytes or are associated with increased red cell turnover reduce the glycation and result in lower HbA1c level. Acute or chronic blood loss, hemolytic anemia, end-stage renal disease, and splenomegaly are the conditions associated with spuriously lower HbA1c levels. Hemoglobinopathies may show falsely elevated or decreased HbA1c levels. In general, patient with sickle cell trait, HBCC or HBSC, the HbA1c measurement may be quite unreliable. The HB variant, which is commonly in Southeast Asia region, may produce some assay variability depending on the assay method used. So coming to the fifth component or sixth component, that is endocrinopathies in anemia. So what are the anemias which can induce different endocrinopathies? And two very bright examples are thalassemia and sickle cell anemia. So, endocrinopathies in sickle cell anemia, endocrine disorders in sickle cell disease have multifarious causes. For example, because of the tissue hypoxia, chronic anemia, iron overload states, high energy demand, genetic influence, and malnourishment, anemia may be produced. And the most common endocrine disorders in sickle cell disease are growth delay, osteopenia, hypogonadism, and diabetes mellitus. So these are the endocrine problem that can manifest in a patient with sickle cell disorder. Similarly, thalassemia major especially can lead to various endocrinal abnormality, and these are the various studies in the cohorts of thalassemia patients, and then they have tried to find out the different endocrinopathies associated with them. For example, hypogonadism is the most commonly found abnormality in a patient with thalassemia major, followed by short stature and growth hormone deficiency. We can find diabetes mellitus, primary hypothyroidism, and hypoparathyroidism also in patients with thalassemia. So we are almost at the end of our presentation. So summarizing what I have told today, endocrinology of anemia is a very important concept, and endocrine system is closely related to anemia and its various causes. Endocrinology of erythropoiesis we have discussed, like how erythropoietin as a hormone is a very important and pivotal role in erythropoiesis. The second is anemia as a comorbidity in endocrinopathy. We have discussed anemia can be found in various other endocrine disorders like diabetes, thyroid, parathyroid, hyperparathyroidism, all this condition. Then we have discussed anemia as a diagnostic tool for endocrinopathies. In some endocrine disorders, we can diagnose anemia. We can diagnose the condition by detecting different types of anemia. Anemia is a confounding factor. We have also discussed as HbA1c measurement. Anemia as a therapeutic tool we have also discussed. For example, therapy for anemia can actually therapy for endocrinopathies can actually improve anemia, and there are some drugs in different endocrinopathies where we when we use we can induce anemia also. So we have to be alert on both the sides. Then we have discussed some of the anemia condition like thalassemia and sickle cell and how they lead to various types of endocrinopathies. So that finishes my presentation. Thank you again. Thank you for your patient hearing.
Thank you, sir. At the outset, sir, I would say, sir, it was a fantastic session where we had taken all 360-degree view of endocrinology and anemia, sir. You have touched upon in a very simple and very comprehensive way. And for that, sir, we are very, very thankful to you. But, sir, our session
Thank
is not completed without the question answer sessions. And I was watching the comments because Dr. Kalra was not there today, but he has already given his inputs. So I will read out the comments on endocrinology of the session with Dr. Sanjay Kalra. So first comment he has written is that iron abnormalities can be a cause of endocrinopathy,
you.
a
Yes.
comorbid condition, and a confounding factor, which you have already just evaluated as well as elaborated in details. Iron can be a cure and also a cause of ill health and a concern while using other endocrinotropic drugs. Can you elaborate on this, sir?
Yeah. I think all the points I have discussed on that. So,
Yes.
iron abnormality can be a cause of endocrinopathies. I have already discussed. We have also discussed about the sickle cell and the thalassemia, how iron overload condition can lead to various endocrine abnormality. It's a comorbid condition. We have discussed about its association or anemia association with diabetes, hypothyroidism, adrenal insufficiency, hypopituitarism, all this condition. It's a confounding factor we have discussed, like how HbA1c can be confounded with anemia.
Right.
Iron can be a cure for endocrine abnormality. It may not be exactly correct because, but iron therapy can actually be of advantages in patients with diabetes and CKD, where while improving the anemia, actually the progression of CKD is halted and there would be a better outcome.
Right.
Iron is also a cause of ill health. We have discussed like iron overload can lead to various abnormality, and it's a concern while using other endocrinotropic drugs like when we are using metformin or pioglitazone, the deficiency B12 or the hemoglobin deficiency can also happen. So all these factors are very important, and in fact, while preparing the slides, I had taken a cue from Dr. Sanjay Kalra that what should I should be speaking. Then he just gave some 4 5 important comments on that.
Yes, sir. The second comment, which is very important, sir, can you elaborate on this? Is Dr. Sajjad Kala is saying iron can influence effect of other hormone-related therapies.
Yeah, yes, yes. So iron can influence or affect other hormone-related therapy, and we have discussed uh, for thyroid, there is an enzyme known as thyroid peroxidase, which is a very important step in production of thyroxine hormone, and iron is a very important component of that TPO enzyme actually. So when iron is deficient, then those group of children will have more chances of goiter and also more chances of hypothyroidism.
Yes, sir. So, sir, then, sir, we start taking question answer as well as greetings from doctors from where you are practicing very nearby. Dr. Ansul Singhal, he is again an endocrinologist practicing in Bhilai. He's a regular viewer of our session, sir. Is greeting you. Good evening, sir. Apart from
Good
that, sir,
evening.
there are questions coming from Dr. B.B. Sarkar. He is saying that anemia in diabetes can cause liver problems like cirrhosis. Can you elaborate on this, sir?
Actually, anemia per se may not lead to cirrhosis of liver, but there is a condition known as hemochromatosis.
Right.
Hemochromatosis is a condition where there is a iron overload states. There are some genetic causes of hemochromatosis, like there are some genetic abnormalities where iron overload is there in reticuloendothelial system, and there are some acquired causes. Acquired causes like when there is an hemolytic anemia, for example, like spherocytosis, for example, sickle cell disease, for example, thalassemia, where there would be rapid destruction of the hemoglobin, so more amount of iron gets deposited unless chelation has been given. And in those conditions, in hemochromatosis and all, iron gets deposited in the liver and also in the pancreas. In the liver, it leads to deposition, may lead to severe insulin resistance, and also in chronic liver failure, and also in pancreas, when it gets deposited, it leads to poor insulin secretion. So in either way, it leads to chronic liver disease and also diabetes.
Right, sir. So there is a greeting from Dr. Ashok Sharma. He's again our regular viewer, and he has really congratulated you for such a wonderful and informative topic, sir. Now I take
Thank you.
question.
Yeah. Mr. Basu, I am not able to hear you.
OHA cause it, how to detect its symptoms biochemically, and he is thanking you for already giving the answers. At the same time, sir, he is saying that I could manage the defaulted POTS patient rationally by using, he is already giving the details of the patient. Defaulted POTS weight is 50 kg and is now on Novomix 10 unit BD. Can we add metformin sustained release 500 milligram plus pioglitazone 15 milligram or control only with insulin? Second question is posing that, sir, how long insulin can be given till the AKT is completed? If the patient is vegan, can we give protein powder as well? So it's a long question, sir. I think you have to give part by part answers.
Yeah, yeah, yeah. So the first part is regarding euglycemic diabetic ketoacidosis, and it's a very important question he has asked. And euglycemic decay is not a very unusual thing. It happens with a drug which we use in diabetes known as an SGLT2 inhibitor. Unfortunately, when SGLT2 inhibitor is used in patients who are in stress, who are dehydrated, who have renal abnormalities, probably they may land up in ketosis, and that may lead to euglycemic decay. There, actually, the blood glucose will be normal, but the patient will have ketosis and acidosis. So that's known as euglycemic decay, and the symptoms and signs won't be that dramatic like that of the diabetic ketoacidosis, but the patient may be unwell and there would be acidosis and ketosis. So there the patient probably needs an admission with IV fluid with insulin therapy that can be given. Regarding the second question, what he has asked is that patient is a defaulter Cox, and he is suffering from tuberculosis and probably on anti-tubercular therapy. And there, once the patient is on anti-tubercular therapy, the insulin has to be continued until the ATT is over. And we can use metformin definitely if the patient is able to tolerate. There is no vomiting. We can give Metformin we can give pioglitazone also, but insulin is definitely required during antitubercular therapy.
Thank you, sir. I think you have taken the question wonderfully. And sir, now we are also getting comments from Dr. Anand Purandare, who is again one of the regular viewer from in our channel, sir. He is again saying, but for a fantastic, wonderful session, sir. Thanking you. With
Thank
this,
you,
sir, we
thank
have
you, thank
yes,
you,
sir.
Mr.
With
Anand.
this, sir, we have come to the end of this session, sir. And I think you have already seen that question answers posed to you as well as thanks and greetings being posed to you, which clearly suggests that how wonderfully you have taken the session, sir. I need not to once again reiterate the same thing, sir. I just say that, sir, it's been wonderful addition in our journey and talks with Dr. Sanjay Kalra. We would love to hear you, sir, more in future days. And with this, sir, we thank you and good night and Jai Hind, sir. Your final comment, sir.